Thanks, everyone. Some of us know this case, but I found it quite interesting in terms of seeing the whole picture that we don't get to see with transplant patients. So going on, we got a 19-year-old female. Just a bit of background: she, at age of 8, was diagnosed with bronchiolitis obliterans and had recurrent infections. She was worked up for bilateral lung transplant in June 2025. This was at first complicated by primary graft dysfunction, requiring as well as a fluid collection, which she required a washout for. She responded quite well and then was put onto immunosuppression, which included IMF and Tenmolis. I also took some TV debates to therapy as well as Valgia and Cyclophosphamide. She was doing well from June until December last year, but they re-presented in January to February with low oxygen sensor on home oxygen associated with a cough and weight loss. This was in the absence of fever and night sweats. She was admitted, she received potassium and azithromycin for 7 days. She improved quite well and then was discharged with prednisone, 40 milligrams daily for 7 days. At this point in time, she had a negative workup on TB, but also had multiple BALs with no features of rejection and negative cultures. Prior to her discharge in February, she was noted on one of the BALs to have Kaposi's sarcoma, so the modular aggregates of small capillaries and intraalveolar plant macrophages with leukocytin and fibrin. At this point in time, she received amphotericin B for Candida species and then treated with 1 cycle of paclitaxel and then discharged. She was fine, and then in March developed a 4-day history of progressive dyspnea, fever, rhinopharia, and pleuritic right chest pain. She was admitted for an extensive infectious workup, which was negative, and noted to have chest X-ray that showed bilateral infiltrates. The initial working diagnosis at this point was could it be infection or could it be rejection, and BAL was repeated, where they found a single yeast in 1 macrophage, which resembled histoplasma species, and they were concerned for the possibility could this be a fungal infection. At this point, we were consulted as ID to treatment for fungal infection, and she had no response. It was 5 days that she was on potassium and a case in empirically for an infection. This was her chest X-ray, which shows progressive bilateral, perihilar, and interstitial infiltrates. And this is my poor attempt at just drawing out the flame-like hemorrhage, flame-like infiltrates. That was quite interesting to see. I've never seen this before. I've probably seen it, but I've just never looked at the X-ray as intense as we did with this case. And this was the CT chest. We didn't get a nice picture, but it just shows the extensive infiltrates on the right apical area as well as on the right middle lobe. So this brings me to my talk of pulmonary Kaposi sarcoma post-transplant. And again, it was quite an interesting look through the studies because there's not much in terms of clinical data on pulmonary Kaposi sarcoma in transplant patients. But why this case was interesting was because pulmonary KS is quite rare as we thought, or I didn't think about it as very common. But with this case, she was on empiric antibiotics and just didn't get better. So diagnosis took quite a long time and delayed treatment. But KS can present with a symptom complex that is similar to infection as well as rejection. and a delay to tissue diagnosis just increases morbidity and mortality. So the objectives of this presentation was to really look at the epidemiology and pathobiology of HHV8 associated post-transplant KS, and how we could translate this data into what we could do as South African clinicians to recognize it early and to treat it early. So some interesting facts on KS on a US registry, where they looked at the incidence of KS sarcoma in lung transplant patients, comparing it to kidney transplant. And they found 2 times higher incidence of sarcoma in lung transplant compared to kidney transplant. And 64% of those patients, there was post-transplant HHV8 infection, particularly from donors who had HHV8. And about 67% mortality across the series of cases that looked at donor-derived KS. So why should we really worry about this? It's really that KS is not just a tumor. There's a viral oncologic complication due to innate immunosuppression. And we don't really think about it in South Africa, the first, or at least from my side, that we think about infection first as we naturally would, and then we don't have data in South Africa to suggest what the real incidence of AS or HHV8 is in our country. But it is something that we need to think about practically. It's not just theoretical, because imaging and symptoms will assist the diagnosis, but biopsy confirms it. So the question that I posed to the floor is, if you had a patient who was post-lung transplant, who recently received intensified steroids, presenting with worsening hypoxia and diffuse infiltrates, what would your differential diagnosis? Excellent.
You asked about it.
Okay, thank you. So I'll go to
how did you finish? It should be easy. What's the differential diagnosis?
I'll give those someone who's been compromised insufficient, and this is post-lung transplant. So you go including viral, bacterial, something.
Well, okay.
So there's viral CMV beautiful to learn to pick up. I think going through please.
Sorry, I'll help you now.
Oh yeah.
Thanks.
Okay. I think going.
No. Like you rightly said, infection is something to think about, particularly bacterial, respiratory viruses, CMV, TB, as well as fungal and PJ. Also think about rejection or chronic lung allograft dysfunction. Drug or aspiration, so drug pneumonitis, pulmonary edema, and aspiration pneumonia. But we're focusing really on viral oncology. So 2 things to think about would be post-transplant lymphoproliferative disorder and sarcoma. When there's a pattern of non-resolving infiltrates in a patient who's just had transplant. And the practical point is that even though we think about infection and rejection, KS might still coexist in that scenario. So we shouldn't let a single hypothesis cloud our judgment and not think of KS. And just a bit of history, which was interesting. Moritz Kaposi first described the tumor of sarcoma in 1872. And then in 1994, Chang and colleagues identified HHV8 in those KS lesions in patients that they saw. And in the transplant era, the Kaposi sarcoma is really recognized as a real complication of impaired immune surveillance. And HHV8 is required for KS tumorigenesis. So the virus can be latent either in the recipient or in donor-derived transplant. And most of those spindle cells can be latently infected, but it will enter lytic replication, causing paracrine signaling when there's some immunosuppression. And core message would be that the net effect of immunosuppression is what really predisposes patients to developing those. And why steroids matter in this case, or I looked at the steroid component that the registry, this registry data didn't specifically isolate a single drug that could predispose the patient to KS, but steroid escalation really is just, like I said, the tipping of the net suppression, the net burden of immunosuppression. So it is important to think about KS in the space of CMV as well as post-transplant lymphoproliferative disorders. So looking at the large transplant data sets, it's a US registry that looked at about 250,000 organ recipients across 17 US registries between 1987 and 2004. And what they found was that 163 Kaposi sarcoma cases were observed at follow-up. About 2 times the incidence for lung transplant recipients for KS compared to kidney recipients. And it was about a 2.7, almost 3 times incidence rate for patients who are non-white compared to the white recipients. And a 2 times incidence ratio for non-US citizens. So really the risk signal is strongest where HHV8 exposure is more likely and that the net suppression, immunosuppression is deeper. But there's no single drug, as I said, that affects the net state. It's rather a combined effect of immunosuppression. And how do we use this clinically? And it's really just that lung transplant patients have a lower threshold for non-infectious tissue diagnosis, or we should have a lower threshold. And that steroids, if the patient has been exposed to steroids, we should think about it, or it should go further up the diagnostic thought rather than below. And in South Africa, we should think about that by patients who are immunosuppressed, that is, around compared to the rest of the world. And again, just to note that we don't have we've got a paucity of data of lung transplant in KS in South Africa, so it makes it a bit difficult to specifically say what risk we have. And then there were a couple of case series that described pulmonary KS, and in a donor-derived series, there were 22 recipients, but 6 of them were positive for HHV8 in the donor, and 64% of them had evidence of post-transplant HHV8 infection. almost 67% had developed KS, who developed KS had died. And in a single center cohort, they looked at 467 transplant recipients, where 90 cases received increased risk donor lungs, which included 13 from men who have sex with men. Of those, 30% or 31% developed pulmonary KS who received MSM donor lungs, and the median time to diagnosis was actually a year, 365 days. 3 out of the 4 had improved after immunosuppression reduction and a change from a CNI to an mTOR strategy. And in terms of the pooled literature, and there's almost 60%, 58% mortality among patients with reported pulmonary KS in lung transplant cases, and almost 40% response to treatment in the same pooled review. But just to note that these are just case reports and case series, so there's no real big studies that were done on this. But in South Africa, in terms of the exposure, there was a multi-country in a study that was done looking at Southern and Eastern African patients. We have a cohort with about 2,400, and they found that 17.6% seroprevalence of HHV8 in South Africa. There were older South Africa, Johannesburg and Soweto cancer control donor data, where they reported a 32% HHV8 seroprevalence in Black South Africans, and a renal transplant blood donor study that found a higher seroprevalence in non-white South Africans, which supports a plausibility of higher incidence and post-transplant KS for South Africa. But what I didn't find was a dedicated South African lung transplant case. So there is an absence of data. But the local implication basically would be that to think about it as part of the diagnostic strategy. So just going through the pathogenesis of KS, really just there has to be HHV exposure or reactivation, coupled with an intense immunosuppression. Will cause latent endothelial spleen cell infection that leads to paracrine signaling, and that then results in a multitude of cytokine and angiopoietin, as well as vascular endothelial growth factor, together with viral products that amplify angiogenesis and inflammatory recruitment that ultimately results in three processes, and that's proliferation of spindle cells, the inflammation locally that causes a cytokine-rich lesion, and that causes angiogenesis. So that's the basics of the pathogenesis. Yes. So what does this mean for management? And what the literature basically supports is there's three principles. One is to reduce the net burden of immunosuppression, and that in most reports is shown to be the first management strategy. Of course, it's the trade-off between tumor control and rejection risk, but in the clinical setting of that patient, it is something to think about. Principle 2 is to consider a move from CNI to an mTOR treatment strategy. And sirolimus and everolimus combines immunosuppression, but it also has the potential for antiproliferative and anti-angiogenic effect, so protecting the patient from further development or progression of KS. In a 2025 lung transplant cohort, they looked at four cases of KS, and those who moved on to an mTOR strategy, 3 of them improved at follow-up. So even though we don't get involved in the transplant decisions, it is something that is interesting to know that this is an option. And I guess we should be part of that as ID. And then the last principle is to escalate oncologic therapy for visceral progressive disease, and they looked at liposomal doxorubicin, which was reported systemic therapy for lung transplant failures. Some patients would need airway intervention or stenting, but it all depends on what the clinical context is and what the overall complications are in that patient. And there is no antiviral treatment for AS that's been yet. And then just in terms of outcomes and prognosis from the studies that I looked at, there was 58% mortality in patients with pulmonary AS. 39% treatment response, a 67% mortality in donor-derived KS cases, and there were 2 cases that they looked at in 2008, which showed a 12-month survival after diagnosis and 3-month survival after diagnosis. and a 26-month disease-free interval after multimodal therapy in a 2022 phase 2 grant. These are just case reports, and again, not large studies. So the main message here is delayed recognition causes increased morbidity and mortality. So best to think about KS earlier rather than later. So what can we do as South African clinicians and teams is to mitigate the risk and again treat the net immunosuppression, recognizing HHV8 earlier, even though it's not part of the transplant screening. It is something that we should perhaps think about in transplantation. And again, to recognize earlier, and bronchoscopy should not be only targeting diagnosis of infection, but also for KS and for histological diagnosis. And obviously to optimize treatment. Again, we're not part of this decision making, but it was interesting to know that a change from CNI to mTOR is actually associated with good outcomes.